Yeah, congratulations. Excellent. I am sure is Gabe on? Is I am sure Gabe would want to do the honors of introducing Jason. So you guys may have to bear with my intro. I'm sure Gabe will join. Um, and I was saying Jason's Jason is currently a chief surgical resident um, and at Georgetown University. We had the privilege of getting to know each other and work together when he did. So during surgical training, they have 2 years of research years. And Jason actually spent those 2 years here in Boston where he actually worked with Gabe in Gabe's surgery and AI lab and surgical informatics lab. And also, he did the master's program here. So he's a graduate of this program, and he was in our course. And I got the privilege of getting to work with him. He was a TA for us, I think, and with Shandu. So he was he's an expert in this content. And I had the privilege to write a paper with him, which he may refer to today. That's actually been a truly seminal paper that has gotten a lot of citations and just been really well received around kind of how to implement digital health solutions and kind of what do health systems really look for when we're doing that. And I frequently use the tables and images in talks I do. So Jason is finishing his last year of surgical residency. And then he is doing a minimally invasive surgery fellowship at the University of Michigan next year. So, congratulations, Jason. You're almost through residency, and we can't thank you enough for coming back to the course and being with us and sharing sort of some of your knowledge and skills. And I think he's going to talk a little bit about the work and the work he's done, practical applications as he's moved from sort of pilots to scaling AI and digital health innovations. But Jason, welcome and thank you for doing this.
Thank you so much, Adam. Yeah, it's such a pleasure to be back. And this course I think was such a huge inspiration for the paper Adam was referring to, which I'll talk a little bit about, and um, honestly, just like a huge catalyst for me to kind of get more interested in digital health as it relates not only to surgery but digital building and building digital tools more broadly. So just as a bit of background, as Adam mentioned, I'm a surgery resident in Washington D.C., and I was in your shoes. Um, 3 4 years ago, I took this course in 2021, and then TA'd it. Actually, TA'd it with Shandu in 2022, and it was I mean, I know the semester is kind of coming to an end, but I would highly encourage you to make as much use as you can of the knowledge and expertise that Adam and Gaurav and Gabe and all the other speakers who come to the class have offered, and also your colleagues. I would definitely encourage you to keep in touch with your colleagues after this class too. My experience, both as a student and as a TA in the class, was in the master's program. It was easily the best class and most formative class for me. So would definitely encourage you to make connections during the class, and definitely not let the experience and knowledge from the class end when the semester ends. But in any case, so again, yeah, congratulations to all of you guys on identifying huge sort of clinical problems and working over the course of the semester on addressing them. And so just to preface what I'll try to focus on over the next hour or so is when kind of my thoughts around our project when I was actually in your shoes just a few years ago. So in 2021 2022, I was nearing the end of the course, and just like with this semester, when I was in the course, there were several very brilliant, promising ideas that my colleagues had come up with during the course. And I was kind of sad as the semester was ending that the end of the course might be kind of the end of the road for some of these ideas. And at the same time, as Adam mentioned, I was also working in a research lab that was run by one of the course faculty Dr. Gabriel Bratt at BIDMC. And so at the same time, the course was ending and I was wondering what would happen to all my colleagues, amazing ideas. And at the same time in the lab, I was kind of wondering similarly how all of the, uh, you know, clinical decision support tools we had built in this very sterile academic research lab environment could actually be tested and evaluated in clinical practice. And so I kind of came to Adam and the rest of the course faculty and some of the other people I'd worked with, over the course of the semester with this concern. And we kind of, all started to think about next steps. I think about next steps for people who wanted to kind of continue this, their projects moving forward beyond the course. And so that's kind of the inspiration for a paper that we ultimately wrote and what I'll be talking about as well. All right. So, so as I mentioned, we, towards the end of the course kind of all came together and wanted to kind of think about and put some, specificity to how to take an idea forward beyond this course, or just even, regardless of whether you're in the course or not, if you have an idea that you're excited about and you want to see it, deployed in the real world, then, we wanted to think a little bit about next steps. So there are three kind of next steps or challenges, perhaps that we kind of came up with, and they're kind of summarized in these 3 bullet points here. One, of course, is fairly obvious, is to build a good tool, and that sounds simple and obvious. And I'll go into a little bit more depth as to what I think that means in a second. But I do think that there's some nuance around building a good and useful tool, and I also, to be fair, I also think that probably many of you over the course of the semester have already done this, but I think it's important to touch on some of these nuances. And then the second element is deploying your tool in a clinical setting, which is the main focus of what I'll be talking about. And then the third is using your tool once you've accomplished the organizational and technical task of deploying your tool, using it to ultimately change physician behavior. I guess I should say more aptly user behavior, because it's, patients clearly are potential users for some of the tools you guys are building, and other types of audiences as well. So those are the 3 kind of categories of things that I'll touch on. The first is building your tool well. So what does it mean to build a tool well? First, I should clarify by saying that much of the work that I focused on, in the lab and also over the course of my master's program, was on building prediction tools and clinical decision support tools. And so a lot of the content here kind of focuses on that, but I do think that these concepts are broadly applicable to other types of digital tools too. And so it does sound like a fair number of the projects you guys are working on, and it involves some element of, clinical prediction tasks and, using algorithms. So hopefully some of this is relevant and relatable. So first I'll start with a maybe basic and potentially perhaps obvious step of what it means to build a tool well, and that I think one of those first steps is to identify and comply with some sort of established guideline or best practice for developing your tool. And so in the world of clinical prediction tools, there is a guideline for how to develop them properly, it's in their earliest stages, and that guideline is known as the tripod guideline. It's created by the Equator Network, which some of you may be familiar with. And so some of my colleagues and I in the lab and also in this course wanted to know whether published tools published prediction tools, focusing specifically on surgical literature, just because that's what I personally am most familiar with, whether those tools that are available and have been published in the literature mainly ones that predict post-operative outcomes, whether or not they comply with these guidelines or not. And interestingly, what we found is that first of all, around most of these published tools exhibit around 70% compliance on average, which actually, I'll be honest, was a little bit higher than I was expecting, but it still clearly leaves a fair amount of room for improvement. And that the area where most published tools were least compliant was in the area of external validation, which essentially boils down to testing your tool in new environments and on new sets of data that your tool hasn't seen before, and essentially seeing how well it works, which is a critical step in knowing if your tool will be valuable in the real world. So, you know, following these established best practices, I think ultimately can lead you towards building a high quality tool that's been robustly externally validated. And so, as a specific example, some of you may remember or have seen this paper that got a lot of attention a few years ago. For a bit of background, Epic rolled out rather a sepsis prediction tool a few years ago that came under a lot of criticism for a number of reasons, that many of which related to its suboptimal real world performance. And one of the criticisms around this tool that they built was its lack of external validation. And so, they trained their model on data that that Epic had available to them, but they didn't sort of externally validate it on very robustly on specific sites across the US. And so when they rolled it out to various hospitals around the country, different hospitals saw big fluctuations in performance. So that was one of the criticisms, and of course, is an element of this best practice that I just described, the tripod guideline. And so, again, kind of just reinforcing the fact that following any established best practice that may exist for the kind of tool you're developing is very important. And another nuance here is that sort of another area where this tool was criticized in was in its design. It was designed in such a way that it often did not tell something that the clinician or the user didn't already know. And so, for example, the model performance metrics that they use to describe how well the sepsis prediction model performed, they reported excellent, performance metrics, but the prediction that they used to calculate those performance metrics was often delivered to the clinician around 3 to 7 hours after it was clear from the chart that the physician had already made a diagnosis of sepsis. And so it was telling them something essentially that they already knew. And another sort of, aspect of this is that when, in this paper, when they kind of peered under the hood of the model and tried to identify what features were important in how the model came to its ultimate prediction, they found that that some of the strongest predictors or some of the most important features and whether it predicted whether the patient would develop sepsis or not was a lactate level and whether antibiotics had been written for, which are both excellent markers of whether someone is developing sepsis. But if you think about it, if you have a lactate level available to you, that probably means it was ordered by a physician because they had a high suspicion for the patient, in front of them developing sepsis. And if they've already ordered antibiotics, then they've probably already made a diagnosis of sepsis themselves as well. And so it's this important nuance where on paper, this model, pre-deployment had, again, excellent performance, but in the real world, when you factor in the timing of its delivery of its prediction and the information it was providing to the clinician, it was much less useful. And there are other sort of less, famous examples of this. There are published models that I've read of, computer vision models that are able to predict acute hypoxic respiratory failure from chest X-rays. But one of the biggest predictors is that the model sees a chest tube on the X-ray, or it sees an endotracheal tube on the X-ray, which clearly means that the physician has already made a diagnosis of acute hypoxic respiratory failure. And so if you want to deploy this tool clinically, then yes, it might be extremely accurate, but you have to think about when it's delivering this prediction and whether it's delivering any new information that the user doesn't already know. And so I think the lesson here really is that another element of building a valuable tool is you have to very explicitly define the sort of value that your tool creates before you deploy it. And you have to consider questions like, does it provide information that the user doesn't already know? Does it clarify some specific uncertainty, some specific clinical uncertainty? Or if it's not a prediction tool, then perhaps does it make some process more efficient? Or take less time, or does it make this process cost less? And then this last paper that I think is relevant to this topic is just it's an interesting paper that emphasizes this point that building your product with its specific value in mind and keeping in mind best practices so that you're not building your tool in a vacuum. I think this is an interesting paper that highlights this idea. It was a review article that looked at 65 RCTs that involved clinical prediction tools, and they found that in 40% of these studies there was no clinical benefit to using the prediction tool versus not using the prediction tool and just kind of just the status quo of using clinician judgment. And even though in the real world it did not deliver any clinical benefits, if you look back at the performance metrics of all these tools, they were all excellent. And so I think it's an important sort of reminder in some sense that just because your tool works really well in silico doesn't mean that when you translate it into the real world it'll be useful. Okay, so that's kind of some thoughts that I were inspired by this course around building a useful tool. Someone has a comment in the chat. By the way, if anyone has any questions or anything, definitely feel free to chime in. That's a very provocative title. Okay, so deploying it. So once you build a product to as high a standard as you can, then you should consider deploying it. And so this brings us to the challenge number 2 of deploying your model in clinical practice. And the way I'll kind of summarize this challenge is that it boils down to both a technical challenge and also an organizational feat. And the reason why it's an organizational challenge is because of ultimately the organizational complexity of hospitals. So there are ultimately going to be multiple stakeholders in a hospital or in any clinical setting where it's a hospital or a physician practice or what have you, where you'll need to exhibit the tool's feasibility and desirability and viability. There will be, and we'll get into this in a moment, but there will be end users and also executive sponsors and various people in between that you'll need to kind of convince that this is a clinically useful tool, also a financially viable tool, and also a technically maintainable tool, and et cetera. So that organizational complexity, I think, makes deployment especially challenging for digital tools that you want to build and deploy. And then the second reason why I think this is very complex is not only because of the organizational complexity, but also because of the technical complexity of hospitals. And I think that this stems really from the inherent messiness of healthcare data. I'm sure as I'm sure all of you guys are familiar with, there are so many different sources and types and formats of healthcare data, and many of them are hidden and many of them are unstructured. And some highly technical challenges that are involved in deploying your tool in a clinical setting are getting the right data and cleaning the right data, and then somehow figuring out how to integrate that data seamlessly into your tool, and then seamlessly integrate the tool into a user's workflow. As an example, one challenge is that very few people are probably going to use your tool if they have to like open a separate application and it's not embedded in your electronic health record. And that getting it embedded in the interface of an EHR is a technical feat unto itself. And so those are some examples of things that I think one has to consider. And so, at the beginning, I said at the beginning of, just a few minutes ago, saying that at the end of this course that I took when I was in your shoes a few years ago, we wanted to outline some organizational next steps for how to carry your idea forward. And so here's essentially what we came up with, these 9 bullet points right here. And the way we framed these next steps are not actually exactly from the perspective of someone who's building a product, but instead actually from a healthcare organization's perspective. The way we sort of framed it was, here's ultimately what a academic medical center or some other clinical organization, some other healthcare organization is going to ultimately want to know. And ultimately what help them figure out what they'll need to deploy a new digital tool. And the reason why I think this is relevant to all of you guys is because as tool developers, any organization you approach is going to expect you to answer these questions. And ultimately the responsibility to answer these questions and solve some of these challenges, they're going to expect you to do it. And so it's important to keep these things in mind as you think about deploying your tool. And so I'm going to go into each one of these one by one. But just to briefly summarize them, you have to consider from an organization's perspective, what makes sense as it relates to a product selection approach. I'll go into this in just a moment. Maybe this is obvious, but you have to demonstrate some level of financial value of your tool. It has to have some sort of return on investment, and it also can't, the cost of using and deploying the tool can't be inordinate or disproportionate compared to the financial value it brings. It obviously has to deliver some degree of clinical value. You have to consider what data assets your tools needs. What data that is captured by the healthcare organization is needed in order for your tool to function. You're going to need several people to help you deploy, one of whom is going to be an internal champion. You'll need probably at least one executive sponsor, and someone in the organization with the leverage to corral the resources to help your tool get into clinical practice. You'll need to make sure that your tool aligns with institutional priorities. So it might deliver excellent financial value and have great clinical value, but if it's not, say, a priority of the organization, then it might not be something that they're interested in pouring resources into. And then finally, you have to make sure that your tool has some sort of business or financial long-term operational home, and also some sort of technical operational home, so that once it's deployed, it's not just forgotten about, but there are people and resources available to make sure it stays updated and stays functional and can troubleshoot it over time. So I'll first go into product selection approach. And so, there are essentially 4 different ways in which, sorry, actually, if you could just give me 1 second. I thought someone is calling me from my clinical team. Just give me 1 second. I'm so sorry about that. I tried to carve out time away from the words to give this, but every once in a while, there's still some questions that pop up, so I apologize. In any case, um, product selection approach. So there are four general categories that I think a healthcare organization will consider when they identify a problem and they're looking for a digital tool that solves that problem. Um, One of the first avenues they'll look to, I think, is going to be whether some existing vendor they work with already offers a solution to that problem. So, if you're, as a simple example, if you're a large hospital and you already use Epic, and you want, say, for example, I don't know, like a tool that helps with optimal operating room scheduling or ambulatory visit scheduling or what have you, probably the first place you're going to look is Epic, and whether they have some function, some tool, or some functionality that already solves that problem. Um, if they don't have that as an option, then I think they'll generally move on to some of these other categories. One of those categories might be whether there's um, another vendor that is willing to co-develop a solution alongside them, perhaps some third-party vendor that they don't already work with, but is flexible and willing to work with the healthcare organization to build something that's tailored to the needs of their institution. Um, Another possible avenue is maybe not partnering with a third party vendor to develop a solution, but identifying some other vendor that already has a solution that they can just kind of purchase. And then the final avenue is considering internal development of the tool within their own healthcare organization, relying on their IT and informatics staff to build something that's very kind of tailor made to maybe a site specific problem that they have. And if I had to kind of guess which of these buckets might be most relevant to the kinds of tools you're building, I would have to say probably that probably the green bucket, the internal development of a tool within a healthcare system, or perhaps if you consider yourself, if you consider your product like a standalone product that you want to offer to healthcare organizations, then perhaps the blue bucket. But um, these, I think, are the four main avenues that healthcare organizations will consider when they want to um, solve a problem with a digital tool. There are obviously various advantages and disadvantages to each approach. As I said, if the tool is being built to address a very, very unique site-specific problem that's unique to one healthcare organization, then maybe an internally developed tool might be best. But if if a problem that the organization faces is a universal problem, then an externally built tool that's been well validated elsewhere at other organizations might be better. And so, as a very brief example, I think, this was sort of an example that came up when I was taking the course, because I was taking it around the time that COVID still was, really, at the forefront of people's minds. I think one of the big priorities in the era of COVID was rapidly expanding telemedicine capacity, and this was a pressure that I think uh, that was felt pretty universally by all healthcare systems in the U.S. And so many of them kind of turned to externally built tools from third-party vendors to help kind of address their expand their telemedicine capacity. Same with externally built, SMS-based or chatbot-based vendor solutions to help screen patients and direct them to the right resources. So that's an example of a universal problem that all organizations face, and that can turn to a solution that has already been built. As a contrasting example, one of the more site-specific problems that arose during COVID was unique kind of regional and state level restrictions on postponing elective surgeries and screening criteria for COVID, and visitor policies for COVID, for people who are visiting the hospital. And so for those kinds of more unique problems, many health systems in the news, there were reports in the news of many health systems kind of turning to their own internal software development teams to generate more customized solutions to comply with these local, regional, state rules. I actually think that Mass General Brigham around the same time, Adam can correct me if I'm wrong, but I think Mass General Brigham around the same time internally developed their own tool to comply with, Massachusetts level guidance around screening visitors and employees for respiratory symptoms.
Yep, that's exactly right.
So,
And by the way,
so
just to
that's
simplify, Jason, if you go back to your slide, this actually I find this slide super helpful. It this is kind of the framework we use, and even when we're talking about novel AI algorithms, it's the same thought process that we go through, right? Are we gonna build or buy? This is kind of the process we go through, and I really appreciate Jason sort of putting this together. And I still use it frequently when I'm, giving talks and frankly talking to people when they're asking how do I get my product into your organization or how do I advance things? So thanks for really framing this putting this framework together.
absolutely. I mean, and I'll have to give credit right back to you, Adam, because I think you were the one who gave me a lot of the yeah, gave me the ideas and content to kind of put this together. So, all right. So, product selection is something that, as a healthcare organization, as Adam was just describing, is something that it was probably one of the first things that they're going to want to be able to answer. What's the right avenue for identifying a solution to this problem? Once they've identified the avenue where they want to obtain this, a new tool from, the kind of one of the next questions they'll want to know is whether this tool has a clear path to return on investment. And of course, that the two elements of return on investment are the cost of the tool, obviously, and what sort of financial sort of value it brings. And so there are three general categories to consider when thinking about what kind of financial value your tool creates. One is thinking of it in sort of a fee for service sort of mindset, meaning does this tool increase billable volume in some sort of way? Does it increase procedural volume? Does it increase the number of patients that a provider sees in a given day? That's one way of thinking about it. If your tool doesn't sort of generate value in that way, then there are certainly other ways to think about it. One is a value-based care way. So one way to think about this is a tool, for example, that improves clinical care along a clinical metric that has financial incentives tied to it. So a tool that reduces catheter-associated bloodstream infections or urinary tract infections from catheters. Those are not only things that bring clinical value, but those are very, very closely monitored clinical metrics that are tied to financial incentives for hospitals. And so in this sort of value-based care or even beyond just those two specific examples, if your tool improves population health in some measurable way that's tied to financial consequences, then that's another way to think about your tool generating value for a healthcare organization. And then the third is regulatory compliance. Is there some sort of state level regulation that the tool has to comply with? And if they don't, then there are financial penalties associated with it. And if your tool helps them avoid those financial consequences, then it creates value in that way. That's one aspect of the tool's ROI. The other is, of course, the cost incurred by running and using the tool. One way to think about this is that in the process of adopting a digital health tool, there are not only the upfront costs associated with its upfront implementation, but there are also, of course, ongoing costs and say staffing requirements associated with supporting the tool and maintaining the tool and hosting it over time. And so you have to estimate essentially these upfront costs as well as the long-term costs before you consider deploying it. And once you have these costs in mind, you also have to consider, does the organization have an existing line item in its budget to where this tool might fit? Or is an entirely new stream of funding going to need to be created in order to, you know, pay for these costs? So that's an important thing that the healthcare system is going to need, is going to need an answer to before they consider deploying a tool. And so it's important for you as the person who wants your tool deployed to have some idea of what its value is and what its associated costs are. The third element is, does your tool deliver clinical value? And, to take a very high level approach to this, many of you have probably heard of the Institution for Healthcare Improvements. This idea of the quadruple aim, which is 4 broad categories by which you can measure, clinical value. One is improving the health of populations. Another category is enhancing the experience of care for individuals, or for patients, I should say. The third category of delivering clinical value is reducing the sort of per capita cost of healthcare. And then the fourth category is improving experience for clinicians and staff and other providers as well. And so, again, this is the quadruple aim of organizations that deliver healthcare. And they're 4 very broad buckets, but they encompass essentially every kind of way that a tool could bring clinical value to the organization. And so some sort of metrics that fall within some of these categories include reducing provider burnout, or provider time saving, improving patient outcomes, of course. And then another might be, patient satisfaction. So if you build a tool that impacts some of those metrics in some measurable way, then it brings clinical value to the organization. These 4 buckets are, of course, very, very broad. And one piece of advice that I would give is to perhaps try not to tackle this broad category, say, of improving overall patient experience. But if you can drill down to focusing on directly impacting one very specific granular outcome, then that might be a better way to measure and capture your tool's clinical value. So, for example, it might be difficult for you to measure your tool as one that, in terms of total provider time saved, because that's something that's kind of hard to measure. But if you instead measure your tool as as a tool that, say, for example, reduces the number of unnecessary consultations, and that's sort of an indirect way to measure total provider time saved. And so, focusing on very, very specific granular metrics that your tool clearly impacts, I think is an important thing to focus on when you want to communicate whether your tool delivers clinical value or not. Here are some other things to consider. One is, as I mentioned at the beginning, what data assets are needed for your tool to work. As I'm sure many of you are already familiar with, there's lots of different types of data available in healthcare organizations. There's structured data and unstructured data. There are multiple different sources of these data: administrative claims databases, scheduling systems and administrative systems, and of course, electronic health record. And you have to consider not only where the data you need for your tool resides, but also the appropriate interval for which your tool needs this information. So does your tool need this data in real time? Is it accessible in real time? Does it need this data on a weekly basis, on a monthly basis, to kind of figure these things out to ensure full functionality. And of course, you also have to make sure that your tool is fully embedded within the healthcare system's data ecosystem so that it can send and retrieve data from other applications and from these databases as needed for functionality and for good accessibility. And another thing to consider as it relates to data assets is data use agreements. And so, a healthcare organization is often going to want to engage with a third-party vendor using a data use agreement, which is a sort of data governance structure that allows the vendor to access the healthcare organization's data, but access only the minimum necessary data for tool functionality. And so when you approach an organization requesting data for functionality of your tool, you'll want to know very clearly what the minimum necessary data you need is, because they'll want to know that, because they're only going to want to share as little as possible. So that's what you have to consider as it relates to data assets for tool functionality. You also have to consider who in the organization is going to help you get this tool deployed. And so there are two general categories of people you'll have to kind of enlist for help. One will be an internal champion, and the other will be an executive sponsor. An internal champion is, in some sense, a potential user of your tool or an evangelist of your tool. Ultimately, it's someone who has a very intimate understanding of how your tool meets the specific need of the organization, and not only understands that, but also has the bandwidth and the motivation to sort of orchestrate the adoption of your tool. And by that I mean, orchestrating IT integration and personnel training, and has the leverage to encourage people to use it once it's actually been deployed. Ideally, this person is someone who either is a typical user of the tool or is, works closely with a typical user of the tool, so that they can help you envision how it might integrate into the ultimate end user's ultimate existing workflow. So it's very important to have an internal champion, and it's also very important to have an executive sponsor, or I should actually say that it's important to have multiple executive sponsors. And an executive sponsor is not necessarily a direct user of the tool, but as I was mentioning earlier, someone who has leverage to get the tool to be used. I think in thinking about who would be a good executive sponsor of your tool, you kind of have to think about two executive level strategies. One is the organization's digital health strategy. So, you have to ensure that your new tool is compatible with an organization's existing IT infrastructure and existing platforms, and also their existing information security requirements. And then you also have to consider not only their executive level digital strategy, but also their executive level healthcare delivery strategy. And what that essentially means is whether the tool aligns well with the general purpose and direction and needs of the healthcare system. And so you actually ultimately, I think, need an executive sponsor who's familiar with the organization's digital strategy. So like, chief data officer or technology officer, and then someone who's familiar with the organization's healthcare delivery strategy as well. And this kind of next item goes hand in hand with identifying an executive sponsor, but you have to be familiar with the institutional priorities of the organization you're approaching. It's important, of course, to demonstrate ROI and clinical value, but your tool also has to align with what the organization, is prioritizing and finds important. So, as an example, if the organization you're approaching is very interested in expanding to new populations or new markets or addressing new specific conditions, then if your tool aligns very well with that priority, then it's more likely to attract the momentum necessary for a deployment and also widespread adoption. And then one of the final dimensions to consider is the tool's long-term operational home. And so, as I was kind of alluding to it in one of the earlier slides, your tool kind of needs two separate homes. It needs kind of a technical home and then also a business home. And in identifying where that home will be, you have to identify sort of someone who's going to be accountable for the long-term functionality and operation of your tool. And so you have to identify in some sense who the business owner of the tool will be. Ideally, there should be some operational group or person who's responsible for overseeing the tool and continuing to fund the tool and performing ongoing sort of quality assessments to make sure that the tool is still delivering the value that it says it develops, or that it says it creates. And this might be like some sort of project manager or analyst within the organization. And then the second home you have to identify as a technical home. And ideally, this is a technical group that has the ability to provide technical support for the tool and also maintain the tool over time. For internally developed tools, this might be the organization's existing informatics staff. And for externally developed tools, this technical home might not actually be within the organization, but it might actually be the technical support contract with the vendor that the organization has. And for many of the people in this class this year who are building tools that involve some element of political decision support or prediction, you can imagine that having a long-term operational home from a business and technical standpoint is very important, because as the organization's population, patient population evolves over time, or as regulations evolve over time, your tool is going to need to adapt, and so you're going to need people who can help your tool adapt with those changes, like retraining an algorithm or changing it to comply with evolving regulations. And then the final dimension to consider is ultimately what is needed for implementation. And this actually could be kind of a whole paper unto itself, but to very briefly summarize, the rollout, corralling the resources for rollout and deployment of a tool is a very complex task unto itself. And the dimensions you have to consider are training. So how is it, what are the tools and materials and media that you're going to use to train people on how to use your tool? IT integration, information security. So how are you going to make sure that your tool, meets the organization's existing standards around, information security? What human capital investment is going to be needed? And again, this overlaps with some of the other points that I made earlier, like who's going to be owning the tool in the long term, who's going to take charge of deploying the tool from a technical standpoint, who's going to be the internal champion who gets users to use the tool. And then you have to make sure that your tool, you have a plan for adapting for adapting existing real world workflows and workflows within the EHR so that to fit your tool in. So those are the 9 dimensions that a healthcare organization is going to consider when they're faced with a new product, a new digital product that they want to figure out is worth deploying or not. And therefore are 9 dimensions that you should consider when you want to take the next step with a tool that you want to see deployed in clinical practice. And unfortunately,
Jason,
it doesn't end there.
Before you go too much further, there's a question from Catherine. Just wanted to let her jump in.
Catherine,
Thank you so much. You kind of touched on this, but when you're trying to show the clinical utility of your tool, you advise getting very specific about that. Do you recommend aligning with metrics that the organization is already tracking and prioritizing? I presume you're going to say yes. And then can you speak a little bit about like if you're trying to offer them the ability to track something that maybe they're interested in but currently aren't tracking or something like that?
That's a really good question. Yes, I mean, I think your sort of intuition around the answer is absolutely correct. If your tool measurably impacts a metric that the organization is already tracking, then that makes the job easier for everyone. It makes it easier for you because they're already capturing data that's important for you to justify the clinical value of your tool. But um, but uh, uh, but that's not the only way to those aren't the only metrics that I think are important. So uh, your follow-up question around whether it's worthwhile pursuing metrics that maybe or focusing on metrics that the organization isn't already focused on, but perhaps is interested in focusing on, is a very good point. So I'll give you an example from some of the work that we did in our lab. So around the time that I was in the lab at across the street at Beth Israel Deaconess, um, the opioid crisis very much was front and center, in the news, and one of the metrics that the BI was very interested in measuring was opioid overprescription after surgery. They kind of took it upon themselves as an organizational mission to reduce the number of excess opioids that they were sending patients home with, because they were worried that those excess prescribed opioids would make its way into the community and be misused, and bad things like that would happen. And I think that institutional priority came from a broader state level priority around the same, like limiting the amount of opioids that came from healthcare organizations and were improperly disseminated into the community. And one of the problems that the BI faced was that there was not a whole lot of transparency or visibility, I should say, around what happened to patients after they were discharged from the hospital with these opioids. And so one of the projects we worked on in the lab was trying to measure the amount of opioids that patients consumed after they were discharged from the hospital. And so we ultimately built, a kind of rudimentary tool, like a text message based tool that kind of periodically sent messages to patients to record how many opioids they were consuming at home, and measured that against how many in the EHR it said that they were prescribed, so we could figure out how many excess opioids were sitting in their medicine cabinet that were being unused, and then we could design interventions around reducing that number. And so I think that's an example of starting to measure a metric that your healthcare organization doesn't already measure, but aligns with some institutional priority that they have. Is that helpful? Yeah, okay, great. So the last 2 points I'll make is that, I think so the 9 dimensions that I just described all revolve around the organizational complexity of large healthcare organizations. And these organizations are not only organizationally complex, but also very technically complex. As I mentioned in the data assets category, your tool invariably uses many sources of data. And hopefully by this point, you've identified what data assets your tool needs. And so now kind of comes the highly technical task of actually getting your tool to store and retrieve and analyze that data. And I'm not going to go into too much technical detail here, but I do think that some general understanding of what must happen so that the buttons on your tool actually work when you click on them, I think that's very important to understand. And to draw a parallel between the technical complexity of healthcare organizations, many companies are also very technically complex and have teams that called like machine learning ops teams or ML ops teams or DevOps teams that can take tools that have been internally developed by their software development teams and work on the very highly complicated technical task of deploying them. And so that's essentially what I sort of I'm about to describe, which is the sort of some things to consider as it relates to the technical task of deploying these tools. And so some of you might be familiar with this idea of a ETL framework or an extract, transform, load framework, which kind of describes a sort of pipeline for extracting and harnessing data from a healthcare organization for some purpose. So, for example, a functional digital health tool, um, in order for your digital tool to be functional, it has to extract data from various, databases in the healthcare organization. It has to transform it into a data format that is meaningful for the tool, and then it has to load it into your tool's interface in a way that is meaningful for the end user. And so when you think about the technical task of deploying your tool, you kind of have to think of it in a reverse extract, transform, load fashion, or reverse ETL fashion. First, you have to kind of envision how you want your tool to present data, and what data elements your tool will display to the end user. Once you identify that, you have to identify what format that data needs to come in, and that boils down to the data standards and ontologies that your tool needs in order to work. And then the final step of this process, you have to identify where your tool will come from. You have to understand the format of the raw data and where that raw data resides within your healthcare organization. And so that, I know, might sound very abstract, but just as a quick sort of specific example of that, also from the work that Dr. Brett and I and many of the other people in our lab did when we were when I was in the master's program. Here's an example of a very technical challenge that we ran into when we were trying to deploy a tool at the BI. And I think this technical challenge kind of highlights the importance of understanding the technical details of deployment in a very nuanced way. So, this was the interface of a tool that we built that was designed to predict future needs for surgery for patients with inflammatory bowel disease. And that prediction was based on ICD-10 codes of patients that were being seen by gastroenterologists at the BI, and CPT codes from prior visits in administrative claims databases. And one of the challenges we ran into in deploying this tool that relied on data from various encounters that patients had with the healthcare system was delivering a prediction at the point of care. So, one very important element of this tool is that if you're going to predict whether a patient is ultimately going to need surgery for their condition or not, it's very important to deliver this prediction when the clinician is in the room with the patient. If you deliver this prediction after the appointment, like after the patient has left the office, then it's much less meaningful. And one of the things we realized as we were technically deploying this tool is that we were missing data from the encounter that from that specific encounter where the patient was talking with the clinician. We obviously had historical data about the patient, but we had no real-time data about the patient, because real-time data about the patient, like the ICD-10 codes from that specific visit and CPT codes from that specific visit, don't show up in the administrative claims database until days later or weeks later. And if you don't have that real-time data, then it's very hard to make an accurate prediction about what's ultimately going to happen to the patient. And so ultimately what we ended up having to do is make sort of half-baked predictions behind the scenes using the patient's historical data. And then, as you can see here on the left, we had to ask the clinician a couple of questions during the encounter, like, what medication are you about to prescribe to the patient, so that we have access to that real-time information. And so, that's an example of, kind of understanding the nuances of where you get your data from in order to inform your tool's predictions, and understanding, the frequency with which those data sources are updated and what format that data comes in. And then just to very briefly wrap things up, one final consideration after sort of say you've deployed your tool and you thought about the organizational challenges and the technical challenges of deploying your tool is making sure that your tool actually changes the user's ultimate behavior for the better. And this is something that we're kind of in Dr. Brett's lab, which I'm still kind of involved in, we're just starting to kind of study, and we're now learning, now that many of the tools that we've built are kind of we're evaluating them in clinical practice. We're starting to learn that the interaction between users and digital tools is actually very, very noisy. Just because you deploy a tool that theoretically delivers clinical value or financial value does not necessarily mean in the real world that those values are actually going to be realized. And so, as a nice example from a very, very recent paper that actually made headlines in the news, there's this tool published in JAMA Network Open, this past October, that studied large language models and their ability to comprehend complex clinical scenarios and make diagnoses, and compare that against. In the study, they compared LLM's diagnostic capabilities against real human physicians' capabilities, and the headline that was made from this study was that LLMs outperform humans. But if you read the actual paper, the real groundbreaking finding in all this is actually that, even though LLMs outperform human physicians, when you equip a human physician with an LLM as a diagnostic, colleague in some sense, it doesn't actually improve the human's performance. So in fact, what the study found is that supplying the human physician with an interface that like this a chatbot interface that uses an LLM behind the scenes is actually worse at diagnosing patients than just the LLM alone. And this I think this phenomenon is fascinating in the sense that this question arises of how is it that if you give physicians a tool that is superior to their own performance, nothing really still changes. And this is a phenomenon that I think is true not only for clinical decision support tools, but also could be true for tools that automate processes. How is it that a tool that automates a very laborious task is deployed in the real world, and yet no time overall is saved because of perhaps other inefficiencies in the user's workflow? And so, I'll kind of end things there, but I think that this is one final dimension to consider. Just because you've spent all this time, winning over the healthcare organization and corralling the resources for deployment and actually getting it to be a functional tool in your user's ultimate workflow, that's kind of not the end of the road. You also have to make sure that it changes their behavior or changes their decision making for the better. Yeah. And so I'll kind of end there. And this is just I think a neat quote that kind of summarizes these three challenges. Building a good tool, deploying it, and then ensuring that it actually changes the user's behavior, kind of very neatly. Careful design and deployment is ultimately what enables these tools to make a real world impact. So,
Jayson,
line there, and if you have any questions.
that was truly incredible. And I think, really an important framework and set of guiding principles for any of us who are really trying to actually implement technology that makes a difference. So a huge round of virtual applause for truly a fantastic lecture. So thank you for that. We have a couple of minutes.